okay? Feels like a karaoke challenge. Okay. I have a tendency to talk quite quickly as I get through a presentation. If I'm going too quickly, I'll try and keep it slow, but please, just sort of wave, say moins vite, or for God's sake, slow down. Okay, so I'm going to be talking principally about experiments in pay for performance in primary care in the UK, and in particular the effect that that's had on equity of care. Next one, thank you. And the next one. Next one, thank you. Okay, so to begin with, I wanted to make the French in the audience feel slightly better about themselves after hearing Sarah speak about how slow you were with data. So this is results from the first census conducted in England, and it was conducted by the French, or by the Normans, shortly after they invaded in 1066. So essentially they needed to know what it was they'd conquered, and so they did a census of the kingdoms. So the numbers here, the ranks, ranking the kingdoms in order of their tax-raising power, essentially their wealth. So you can see the wealthier areas are all in the south and the east of England, and as you go further north they get less wealthy, and they also noticed that the populace were more sickly and less healthy as they went north and west up through the island. And up one. Okay, so this is the results of the latest census, 1,000 years later. So this is a cartogram, so it looks slightly odd because the local authorities are proportionate to the local population. So London appears huge. This is England. Here we've got Wales and Scotland, geographically large. So this is actually Great Britain, geographically large, but in population terms quite small. The colours here represent mortality. So the greens and the blues are areas of low mortality. The yellows are areas of average mortality. And the pink's high mortality, and the sort of cerise magenta colour is very high mortality. So down in the south and east is where most of the areas of low mortality, the greens and blues, are concentrated, and all the areas of high mortality are in the north and the west, and it gets worse the further north and west you go until you get to our death capital, which is Glasgow. And sorry, just go back one. So the thing about this, the depressing thing about this is these are two charts which are 1,000 years apart, and yet the patterns are remarkably similar, with wealth and good health concentrated in the south and the east. And I think the reason I want to bring this up is to say that patterns of health and equality in England and in Great Britain have their roots at least 1,000 years in the past, and the causes are geological, environmental, to do with migration, socio-economic causes, and so is it really fair to expect primary care practitioners to tackle these health inequalities in the space of 5 or 10 years? The answer is no, but that doesn't mean you can't do nothing, and I'll show you what is possible. So if we advance one, and the next one. Okay, so to begin with, I think a prerequisite of providing equitable care is to have universal access to care. So the National Health Service in the UK was introduced in 1948 as part of the welfare state. So this is Lord Beveridge who set it up, essentially. And so social security was introduced, universal education was introduced, and universal healthcare was introduced. So healthcare free at the point of delivery. And the idea was that once we had universal healthcare, that would solve all our health problems and everybody's health would improve, and there would be no more health inequality. And of course, that's not the case. If you advance one. Part of the problem was that the GPs, the primary care physicians, were paid on a capitation basis from 1948 onwards. And so essentially you get paid according to the number of patients that you have, and at the end of the year, whatever money you have left after managing those patients becomes your income. And so GPs tended to gravitate towards those areas which were more affluent and where there was less ill health, because the population was less expensive to look after, and therefore they would earn more money. And this became very clear very early on in the NHS. So in 1950, the Wellcome Foundation did a survey of primary care, particularly concentrated in the inner city urban areas. And this is what they found. At best, primary care, the GPs were very unsatisfactory, and at worst, a positive source of danger. Essentially, they were saying that the population in these deprived inner city areas would have been better off with no GPs at all than the GPs that they had. And if you advance one. But this was partly to do with the conditions of the practices, so there was no financial support, and usually it was the rogue GPs who were in general practice because they weren't considered safe to wield a scalpel within hospitals, and they weren't considered some of the better GPs, so they weren't getting the good practices out in the more affluent areas. And so at that time, the Royal College of Physicians established a college specifically for general practitioners. It became a specialty in its own right with a dedicated training program, and the government provided financial support for practices in deprived areas to try and attract GPs to come and work in those areas. And advance one. By 1970, the situation had improved, but it was still the case that primary care in the most deprived areas was still stretched. And so Julian Tudor Hart, who was a GP working in the Welsh mining valleys, coined the phrase the inverse care law. Essentially, where care was most needed, provision was at its worst. And advance one. Tudor Hart worked in this village of Glencurrig in South Wales. You can see the Welsh don't really go into the vowels. A small population of 1900, and most of the population, 2/3, were unskilled labourers, the lowest social class in the UK system. Many of them were unemployed because the mining industry was collapsing at that point. So a very deprived population. And what Tudor Hart and his practice nurse did was they conducted what they called anticipatory care rather than screening. So as patients came into the practice to see him, he would screen them their blood pressure, smoking, cholesterol, diabetes, lung function, because it was next to mining community and lung disease was a huge problem. Body mass index, screen them for alcohol problems. And he also was an early adopter in terms of clinical computing systems. So his practice was fully computerized by 1980. And he got to the point where he actually harassed his patients until he'd monitored blood pressure, measured blood pressure of every single patient, down to the very last man who held out, and his systolic blood pressure was actually 250, so it's good they finally dragged him in. He did this for 20 years, and in 1990, if you just advance one, they looked at the mortality rates within that practice, within that village community, and they found that the mortality rate was 94, 6% below the national average. The neighbouring village of Glengwynfi, which is a very similar village with very similar socio-economic conditions, had a mortality rate 60% above the national average. Now that wasn't because the practice there, the healthcare there was particularly poor, it's because that is the kind of mortality rate you would expect from that kind of community. He should have been 60, 70% higher than national average, but he'd actually got it below through this anticipatory care that he'd been conducting for 25 years. If you advance one. So, the Department of Health tried to capture what Julian Hart had done, and other people had done similar screening, anticipatory care and active management of chronic disease to see if they could roll it out across the country, and we're always looking for a way to do that. Julian Tudor Hart was a classical Marxist, so he would have been horrified by the solution they came up with, but that was to attach financial incentives to the kind of things that Tudor Hart was doing. So I'll explain how that came about. So what they came up with was the Quality and Outcomes Framework. So this was introduced in 2004 as part of a new contract for all general practices in the United Kingdom. So as I say, up until that point, GPs had been mainly paid through capitation payments, but their paying conditions had fallen far below specialists working in secondary hospitals, so they were quite a demoralised group of professionals. And the Department of Health wanted to elevate them in status, but also in income. So they were going to raise their income up to the level of hospital consultants. So they could have done this just by increasing the capitation payments, but decided what they were going to do was they were going to increase their income by about 25%, but attach it to these quality indicators. So if you advance one. So in negotiations with the British Medical Association, the GPs, they came up with 146 quality indicators. So the GPs essentially designed the indicators that were going to go into this framework, and very cleverly came up with indicators they knew they could meet. So most of the indicators were concerned with management of chronic conditions, the common chronic conditions like asthma, cancer, diabetes, coronary heart disease. So initially 10 in the original version, but over time that's increased to 19 common chronic conditions. There were also indicators in there for the way that care was organised, for access for patients, and some patient experience indicators. The indicators were allocated between half a point and 57 points, depending on how difficult the indicators were reckoned to be to achieve and the work that was reckoned to be involved with them. Each point was worth, if you achieved the point, was worth £125 for the average practice, so about €145. So if you hit all the targets, that would bring the average practice €145,000 per year. The average practice having about 3.5 GPs in it, and they could then split the money in any way they saw fit. They could invest it back in the practice, they could invest it in BMW, it's entirely up to them. The practices are allowed to exclude inappropriate patients from these quality targets. So if you had a patient that you felt a particular indicator was not appropriate for because they couldn't tolerate a medication, or if they'd very recently registered with the practice and you hadn't had the chance to hit the target, you could exclude them so you weren't financially penalised for missing the target for that patient. Just one more. All the scores are publicly reported, so there is a website that you can go to and you can pick any general practice in the United Kingdom and you can compare their performance on any one of these indicators with any other practice in the United Kingdom. I'm about the only one who looks at it, but it's there if you want to do it. If you answer one. The way the scores are allocated are like this. So this is an example of one of the coronary heart disease indicators. So this is for control of blood pressure. So you've got achievement along the x-axis and points scored along the y-axis. So there is, if you just advance one, a lower threshold that you have to get over in order to get any points at all. And originally those thresholds were all set at 25%. So you'd have to hit the target for at least a quarter of your patients to get any points at all. That was the minimum that was expected of you. And then as your achievement increases, the number of points increases in a linear fashion, and then advance one. Up to an upper threshold, just go forward one. Thank you. Up to an upper threshold. In the case of this indicator, that's set at 70%, but it varies according to indicator. So the more difficult indicators have lower thresholds. So you don't get any more credit for hitting that target for 80, 90 or 100% of your patients. So there's a bit of a buffer zone, essentially, for most of the indicators. So if you manage to control the blood pressure of 70% of your patients with coronary heart disease, you'll get the full 19 points, and that will get you your payment of £1,400. Okay, if you go to the next one. So one of the things that we were particularly interested in is seeing what the effect would be on inequalities in quality of care. So essentially that's what you're seeing here is results from the first year of the QuAF. So we've got achievement, and this is across all all of the clinical quality indicators. And I've divided the practices up into quintiles according to area deprivation. So this box here represents the 20% of practices in the most affluent parts of the country, going down to here, and this box represents the 20% of practices in the most deprived parts of the country. So if you're familiar with box plots, the little line in the middle here is the average, the median level of achievement. The coloured boxes show you how well the middle 50% of practices do, and the whiskers, the best performing and the worst performing practices. And these little dots here are the statistical outliers. These are practices performing spectacularly badly, so thankfully a handful of practices. So what you can see here is there is a gradient. So the practices, the more deprived the area, the lower the average performance tends to be. But you can see the best performing practices across all areas are performing equally well. But if you look at the worst performing practices, there's a very steep gradients. The worst performing practices in the most deprived areas are doing very much worse than the worst performing practices in the more affluent areas. And if you just advance one, then this is year 2 and this is year 3. So you can see by year 3, the situation has transformed. So there's much less variation within practices. And essentially the practices in the more deprived areas have caught up with the practices in the affluent areas, so there's almost no social gradient there at all. And if you advance one, so the reason is because the practices even if you look in the worst performing practices, in the more affluent areas, they've improved by about 10%. If you advance one, but in the most deprived areas, they improved by over 20%. So essentially those low baseline practices performing very badly very quickly caught up. So when we're looking at the activities that were financially incentivized in the space of just 2 years, that social gradient was almost wiped out. So the Department of Health got very excited about this because they thought, ironically, it seems one way of tackling health inequalities is to throw lots of money at a group of affluent professionals. But there are cautions. So if you advance one, this is looking at the, sorry, next slide. That was looking at overall performance on all the indicators. So if you break it down and look at individual indicators, the situation is slightly different. So this is picking out a process type indicator. This is for patients with diabetes having neuropathy testing. So again, here we got the red line is the practice in the most affluent areas, through to the light blue line, which is practice in the most deprived areas. So again, in the first year, there was this large gap, and going up to 2010, the last figure we've got the data for, there's been a convergence. So practice in all areas have reached this similar level of achievement. And forward one. But if you look at outcomes type indicators, and this is an issue that came up before, so if you look at control of HbA1c, there are a series of targets for HbA1c. There's a moderate control and there's a tighter control. So this is the moderate control indicator. So in year 1, again, very wide gap going from the most affluent to the most deprived areas. And that gap hasn't closed. And in 2009, the target was made tighter. It was dropped from 10% to 9%. That's why there's this drop in achievement. And the gap is maintained. So when you look at the outcomes type indicators, where you're actually having to control blood pressure or control HbA1c or get an intermediate outcome, the gap is not closing. So we're able to close it for processes. Do you measure these things, but not whether you control them. And if we advance one, the other issue with a pay-for-performance program is what happens to the things that you don't incentivize. So this is one of my interests, is what are the unintended consequences of paying for performance and financial incentives, is you could introduce new inequalities. So we've been tracking performance on a lot of quality indicators going back to the pre-QoF days, both for activities that made it into the QoF and were incentivized and activities that were not incentivized. And for most of those activities, quality has been improving before the QoF ever came along. So we're not interested in, after the QoF and the financial incentives were introduced, did quality improve? We want to know, did it improve more than you would have predicted or expected, given that underlying trend? And through an act of statistical witchcraft that I can tell you about later if you're so inclined, you can project into the QoF years what you would have expected to see. So that's this zero line here. So what we're saying here is this is the first year of the QoF. If quality had improved at the same rate as the pre-QoF years, it would have been 0 on this axis. So these are 30 incentivized activities that made it into the QoF, and here are 20 non-incentivized activities in the grade that did not make it into the QoF. So an example here would be influenza vaccination for patients with coronary heart disease, that was incentivized. And over here, influenza vaccination for patients with chronic renal disease, which was not incentivized. So you can see for the incentivized activities, for every single one of them, quality improved more than you would have expected. And in some cases, it improved an awful lot, up to 35% higher than you would have predicted. But for the non-incentivized activities, most of them, there was no statistical difference. For some, it was a little bit higher, and for 5, it was actually below what you would have predicted. If you advance one, but by the 3rd year of the scheme, a lot of these, even for the incentivized activities, were reaching a plateau. So they weren't, by year 3, they were not that much higher for most of them than you would have predicted, some of them still higher. But for these non-incentivized activities, over half of them, performance was actually less or lower than you would have predicted pre-QoF. So I think it's what intuitively you would expect would happen. The GPs are concentrating on the activities that you are financially incentivizing to the detriment of some of the activities that you're not financially incentivizing. So if you have a condition which hasn't made it into the QoF, which isn't financially incentivized, your quality of care will probably be worse as a result of this. Okay, advance one. Another inequality that's developed is, because this is all done on practice clinical computing systems, so all practices now are fully computerized, and this data is automatically drawn from their clinical computing system, so we can assess how well they've done. And one of the questions is, there are a lot of different clinical computing systems. They all have to be compatible, but they are different in the way they present data to the GPs. And so here I've taken the 7 most common clinical computing systems, using one of them, System G, as a baseline. And this is looking at the other clinical computing systems to see how well practices that have that system do under the QuAF. So essentially what you're seeing here is the ones with System A, on average, are earning £600 more each year than those with System G. And this here, System D, is actually the most frequently used. These systems here, A and B, are actually only used by a minority of practices, to the extent that the software supplier is now going to withdraw from the market, even though it has the best, the most successful system. So essentially, we don't know why this is. It may be that good practices, or practices that perform well, select a particular clinical computing system, or it may be there's something about using that system makes practices better able to achieve well on the QuAF. But your choice of clinical computing system is associated with how well you perform. Okay, and if we go forward. So the last thing I want to do is just say, one of the questions which keeps coming up is what it's actually like to work under this kind of system and under these financial incentives. And there's going back 200-300 years in British medicine, there's this idea that medicine is an art as much as it's a science. Often that's by default because there's not a lot of science in it. But here is sort of a view of one of the general practitioners that I spoke to, is he does see it as a sort of piece of music, what he does and how he performs with his patients. And essentially what we've done over the last 10 years in Britain is this. We've deconstructed what it is that practitioners do, and we started measuring it. So we know all the little individual components. So that tells us a little bit about what's going on here, but it doesn't tell us everything. The things that aren't counted, measured, financially incentivized are in danger of being forgotten. If you just advance one. And I just want to finish with comments from a piece of qualitative research that colleagues of mine did at Manchester, which was to actually go into the practices and interview them about practice staff, what it was like to operate under this system. And I think this is a quote from one GP, which I think captures a lot of their opinions on this. You just advance one. It's a good idea, it makes things tangible, it quantifies things. We now know what's going on within general practice. We're measuring it, we're incentivizing it. We know how good quality of care is now for a lot of the things that happen within general practice. And if you just advance one, although I hate it. So there's a feeling that something is being lost. And the question is, are we able to do both? Are we able to measure, incentivize and improve quality in this very basic financial incentivized way and keep some of the things which GPs actually came into primary care for in the first place? So I'll stop there because I'm probably raising more questions than I'm answering, so I'll give you a chance to ask some questions.